Okay, so let's start our first webinar of our city chapter. And the topic today is fetal craniofacial and skeletal ultrasound. It's more of a practical overview. And over the next 45 odd minutes, I'll try and underline the practical aspects of craniofacial and skeletal ultrasound. First of all, why? What is the link between craniofacial and skeletal ultrasound? I picked up two areas which have, these are external birth defects. The impact, especially the aesthetic impact it has on the fetus and its life, family, and also even the radiologist in terms of a medico-legal perspective is important in these areas. So it's absolutely mandatory or important that we really go through a structured ultrasound and seek for fine aspects in evaluating these areas. And so let's start with facial clefting. And what's the significance of cleft lip and cleft palate? It's common in Asians, 1 in 6,000 live births, especially in the East Asian population, Chinese and Japanese. It has a relatively low detection rate, though in high-end centers, the detection rate is about 90%. In the lower centers or peripheral centers, detection rates have been as less than 20% has been recorded. So there are a significant number still of facial clefts that are getting missed and are detected as surprises postnatally. So it is important that we pick them all up. And of course, there is a syndromic risk associated with facial clefting. There are at least 300 named syndromes associated with facial clefts, and there is also an aesthetic impact. In fact, apart from the aesthetic impact, the patients with facial clefting also undergo struggles regarding swallowing, speech, hearing, dental problems, and of course, emotional problems as well. So we start usually with a snout view or an angled anterior coronal view of the face and lips, the nose, lips, and the chin. So what we need to look for in the snout view is this, is the skin mucosal line of the upper lip, the intactness or the integrity of the skin mucosal line of the upper lip. Because sometimes a prominent philtrum can sometimes mimic and may fool us into play a trick on us. So we need to really look at this line, the skin mucosal line. For example, let's look at this anterior coronal view. You can clearly see a deficiency in the skin mucosal line over here. There is an interruption over here, suggesting there is some cleft, though the morphology of the nose, the shape and symmetry of the nose is well preserved. There is a disruption of the integrity of the skin mucosal lines under this region. The alveolar ridge or the primary palate is always evaluated with an axial sweep right from the level of the orbits inferiorly. But as you can see over here, the intactness of the alveolar ridge or the primary palate is picked up in the anterior coronal sweep right from the orbits to that of the mandible. As you can see over here again. Next. The incisive foramen is an important embryological and anatomic landmark. Of course, it's an osseous hole which allows passage of the palatine artery and vessel, the sphenopalatine and the nasopalatine vessels through this, but it segregates, it separates the primary palate from that of the secondary palate. The primary palate is the area above alveolar ridge and a small portion of the anterior hard palate, and a vast majority of the hard palate, posterior hard palate, is secondary palate, and also it includes the soft tissue or the soft palate. So now the types. We have this incomplete clefting, which can be a cleft of the lip or the palate. but the cleft does not extend up to the nose, up to the nostrils or the nares. While a complete cleft extends into the nose, it can be unilateral or bilateral. It can be unilateral palate or bilateral palatal clefting too. So this importance or this aspect of reporting incomplete and complete clefting is important because it adds on to the complexity of the corrective surgery later. So in our reporting, it is important to inform whether the nose is involved, the nostrils are involved, whether it's a completely cleft palate or complete cleft lip involving the nose again, or whether it's just an incomplete cleft. There are multiple classifications and types of reporting facial clefting. We don't need to go into the types. What is more important is how well you describe the cleft. Whether the cleft just involves the lip alone, the palate is spared, whether it involves the cleft and the palate, whether it's unilateral or bilateral. As you can see over here, bilateral clefting, or whether it involves only the palate alone, isolated cleft. This descriptive passing on of information is important, and this is an example of a complete cleft. As you can see over here, it's a unilateral cleft. The nose is over here. This side of the lip is intact, while the cleft is on the other side. And it directly and obviously involves the level of the nostrils, extends into the nostril. There's a complete cleft of the lip with that of the extending into the nostril. Now this is an example for an incomplete cleft, or as you can see over here, there is a deficiency. This is the video that I showed earlier. It's a cleft over here, but the nostrils appear spared. Nostrils appear spared. The shape and symmetry of the nostrils are the same. Now, as I mentioned earlier, to evaluate the anterior palate or the alveolar ridge, we need to use the axial view. As you can see over here, a deficiency, very clearly, a deficiency of the palate over here. It is important. The cleft in the palate. So use to identify clefts in the alveolar ridge only with an axial view. Of course, sagittal view too can give some indication of a clefting, but axial view is the key to diagnosis. Now, when you have a bilateral cleft, often you have this type of pre-maxillary protuberance bulging out, or a wedge-shaped tissue in the midline, when it's bilateral clefting, bulging out, and these type of bilateral cleft has a relatively poorer prognosis, are more complex surgeries, and it has an increased association with aneuploidies as compared to an unilateral cleft. So bilateral clefts are significant not just because of the complexity of the surgery, but also because of its increased association with aneuploidies. Role of 3D ultrasound, yes. Surface rendering, yes, helps us to see, as you can see, a complete cleft. There is mild distortion of the nose anatomy. The symmetry and shape of the nose is altered, but it also tells us the alveolar ridge is intact. So it's a complete cleft lip. There is no palate involved here, especially the anterior palate that we can see over here. And it's a complete cleft because you can see the distortion of the nose and extension of the cleft into the nose. This is the advantage of surface rendering. And now, the maximal rendering view, you can see, can help to show us the defect in the hard palate. And the importance of 3D. And the importance of 3D is that it gives vital information to the non-imaging person. whether it may be the patient's parents, relatives, and the surgeons. Non-imaging people get a lot more of value and added information in 3D images. That is why these type of surface rendering images and maximum mode images to show the hard palate cleft is important. And even in the first trimester, especially in high-risk patients, this is the 13-week fetus TBS scan. In high-risk patients, whether the parents have facial clefting, they can be used to identify clefts in the first trimester. It's 30 weeks, and you can see the intactness of the lip over here. Okay. As you can see. Intactness of the lip. Okay. The same with every NT scan image shows us the hard palate. Every NT scan image shows a hard palate, and hard palate evaluation should be part of our NT scan. And every NT scan, the mid-sagittal view, shows us the intactness of the hard palate. So now, if there is a deficiency of more than 1.5 millimeter, more than 1.5, this is a normal image for comparison. There's a deficiency of more than 1.5 millimeter. It is called a maxillary gap, and it increases the risk, or it can be a sign of hard palate clefts. Especially as you can see over here. And as you can see over here, with the larger the cleft, you can see an extent of micrognathia or retrognathia. Large palate enclaves are associated with retrognathia, micrognathia, and also with the ear abnormality. So these are things we need to seek for when we have a hard palate cleft. Now the premaxillary triangle is an anterior coronal view. This is the premaxillary triangle or a retronasal triangle. The base of the triangle is formed by the hard palate, the lateral walls by the frontal process of the maxilla, and the apex by the nasal bones. These are the nasal bones. Now, if there is a deficient base of the premaxillary triangle, also called the retronasal triangle, we are suspicious of hard palate. Though we can't 100% diagnose at this point of time, we raise the possibility, and the baby needs to be followed up around 16 to 17 weeks. Now, coming to the types again. Now, this is the incisive foramen. The portion anterior to it is the primary palate. The portion posterior to it is the secondary palate. One clinically valuable and important embryological point is this. As we can see over here, palates, either cleft lip or cleft palate, anterior to the incisive foramen, that's its embryological significance. Anterior to the incisive foramen can happen either to the left of midline, right of midline, or in the midline. Posterior palate clefts always happen in the midline. As you can see, posterior palate clefts always happen in the midline. Whether it's a complete cleft or an isolated soft palate cleft, they are always in the midline. And that's the embryological significance of incisive foramen. And this is because the embryologically, the palate closes like a zipper from the, or like a zip from the incisive foramen posteriorly towards the uvula. It goes anterior to posterior. It closes this way. And so the mildest form of a cleft is a bifid uvula. The mildest form of soft palate cleft, I'm talking about isolated soft palate cleft, is a bifid uvula. So if you can see an intact uvula, it rules out a soft palate cleft. I'm talking now about secondary cleft, palate cleft, or posterior palate cleft, including the soft palate. So if you can see the uvula, this one, two echogenic lines. This is because the reflections on either side of the uvula get the sound waves on either side of the uvula get reflected more in the background of the pharyngeal fluid in the pharyngeal cavity. And this type of sign, equal sign, as you can see over here, confirms an intact uvula, and an intact uvula rules out an isolated soft palate cleft. So this can be used in every anatomy scan to seek or rule out an isolated soft palate cleft. So in 70% of the cases, you will be able to see the uvula just as you keep the probe into the pharyngeal fluid. In 30%, 7 out of 10 cases, you can immediately see the uvula. In 30% of the cases, you might need to wait for the baby to swallow or take some amount of fluid around to have a good look at the uvula. Now, you cannot see the uvula in the axial plane. You can use the sagittal plane too, just slightly more tougher, or you might need to gain. As you can see, the equal sign. The 2 lines over here, the uvula. An intact uvula rules out an isolated soft palate cleft. So to summarize the facial clefts, they form an important part of 20-week anatomy scan. And it's best to describe the cleft or describe the defect rather than using type 1, type 2, type 3, because it might, the type you are describing may not be the classification the surgeon may be following. 3D is definitely useful for non-imaging people to convey more information, especially to the parents and the surgeons, and also in diagnostic dilemmas. In the first trimester, maxillary gap, interrupted premaxillary triangle, and also the uvula give very useful indications of a normal facial lips and palate. Let's move on to the other aspects. Now, retrognathia. As I mentioned, retrognathia is common or associated with soft palate clefts. I wouldn't go into the theory part of it much, but to not suffice to say, a straight line from the nasea at the level of the on the nasea and straight line, if the full portion of the maxilla, mandible is posterior to the line from the nasea, we suspect retrognathia. And of course, there are a few other lines, MNM, maxillo, MNM line, and other. I wouldn't go into the theory aspect of it, they are available online, but a rough guide is this. If the maxilla lies posterior to the straight perpendicular line, straight line down from the nasea, we suspect retrognathia. But it is important to note that retrognathia, mild retrognathia can be a normal variation. There are people with small chins, so you need to take that into account. You need to have a good look at the parents before calling retrognathia as abnormal. As you can see, the retrognathia is strongly associated both with palatine clefts and also with increased incidence of syndromic abnormalities. Binder faces, you can see you have flattened nasal bridge. It's also called nasomaxillary hypoplasia. This again can be a normal variant. You need to look at the parents, but if there is no family history, you need to make a point that binder faces are this nasomaxillary hypoplasia can be associated with choanal atresia and other type of complications related to the midface. So that's something which you need to be aware of. And we need to report that in our reports. Absent nasal bone. As you can see here, this is a 20-week scan. Absent nasal bone in a Caucasian population, white population, is normally seen in up to 0.3% of euploid fetuses, but in more than 60% of Down's fetuses. Absent nasal bone, Caucasian population is seen in 0.3% of euploid fetuses and more than 60% of Down's fetuses. In our Indian scenario, because of ethnicity, absent nasal bone is slightly more common than 0.3 to 1%, though we don't have robust figures for that. But one point to note is, absent nasal bone is isolated, the risk of Down syndrome is less than 5%. If absent nasal bone in the 20-week scan is isolated, the risk of Downs is less than 5% in an Indian population. So we need to tell them that the risk, palpable risk, there's almost 5% risk that can be associated with Downs, but 95% the baby is likely to be normal, provided it's isolated. There is no other Down syndrome. We don't have baby septal defect, duodenal atresia, and all the other markers of Down syndrome, including ventriculomegaly, thick and deeper in the wrist. So we need to really check for the other markers before calling a nasal bone as isolated. But in our present medical legal condition, it is not a bad idea to add a word karyotyping may be suggested for the patient reassurance so that there is no medical legal issues. Coming to the orbits. Orbits again are evaluated best with an anterior axial sweep. You can see the orbits as in here, right from the orbits. It's the same sweep that I used to tell you. Look for the intactness of the globes, the size of the globes, the symmetry, that they are equal sized. Also look at the lens. Also look at the lens in both orbits in anterior axial. So you can use the coronal view also, but anterior axial is the best. Of course, there are biometric values available. You have the BOD, a binocular diameter, or IOD, interocular diameter. But a rough guide is this: there should be enough space to fit in another orbit between the existing two. Both the orbits should be roughly equal, and there should be another space enough to fit one orbit and one orbit alone. So biometry is useful, and especially if the IOD, the interorbital diameter, is less than 5th centile. There are normograms and biometric charts available. Less than 5th centile, we call it hypotaylorism, and if it is greater than 95th centile, we call it hypertaylorism. Now, microophthalmia is something we need to see. Documenting and visualizing orbits is an important part of your anatomy scan, because these are some things which can really put you in trouble. As you can see over here, the orbits are not distinctly seen. It is, in fact, a wise idea to document the orbits in images. I will come to it. As you can see in baby, you can see a small orbit in the anterior axial view by the previous image. Though we could identify there was some orbital abnormality, the intactness and the complete nature of the orbital abnormality was not distinctly seen. As you can see over here in the anterior axial view, they can be nicely measured. Increased distance, interorbital distance is increased. Small orbits. We need to know that you can have normal orbital globes with normal lens in the 20-week scan, and you can have complete anophthalmos. Repeat. You can have normal orbits in the 20-week scan and have anophthalmos. And all of us know what anophthalmos, missing a child with anophthalmos or having a child with anophthalmos can do to us medically. Why is that? Because all fluid structures can change with time. We'll come back. All fluid structures, whether it is the intraocular fluid within the orbits, CSF within the ventricles, the brain, blood within the heart, urine within the renal pelvis, amniotic fluid within the fetal palm. All these things can change with time. You can have normal cerebral ventricles at 20-week scan and have hydrocephalus at term. You can have normal flowing blood across an aorta, and you can have aortic atresia at term. You can have normal appearing kidneys and have real hydronephrosis at term. Bowel atresias need not present in the 20-week scan, and similarly, intraocular fluid can be normal in the 20-week scan, and you can have an ophthalmos. So that is why documenting orbits is an important part of a 20-week scan in terms of images. As you can see over here, it's not just to see the presence of the orbits, it's important to compare the orbits. You see this? The shape. The shape of this orbit and this orbit. This looks a lot more normal, not more convex. We just move it against it. As compared to this is a lot more flat. These type of abnormal orbits are likely to go into anomalies. This is what we need to search for. This is what we need to document and point out in our anomalies. And this is called, this is a tendency towards microophthalmos, and it might land up as anophthalmos. Also, it is a nice idea to have a good look at the lenses, but lenses sometimes are not difficult to see, especially the baby is not anterior facing. You can see a little bit of echogenicity over there. Again, an echogenicity over here. Cataract, quickly cataract. This one and this one. Let us see in this image. Can you see this? Cataract. This baby had a history of congenital cataract. Mother's grandmother and maternal uncle had congenital cataract. So these type of history is important, especially if there is no history of fetal infection. Of course, an infection charge scheme has to be run on every baby that has congenital as an evidence of cataract. Another practical point in terms of cataract is, if you see an echogenic lens, it is confirmative of cataract, but if you see a sonolucent lens, it does not rule out a cataract. If you see an echogenic lens, it confirms cataract, but if you see a sonolucent lens, it does not rule out cataract. And this point has to be conveyed. All we can say is we are seeing an ultrasound-wise normal lens, but we cannot 100% rule out cataract, but we can tell them it is not. It is not a confirmed case of cataract. That much we can reassure. The lens looks normal for that time. That much can be confirmed. But if you see an echogenic lens, it is cataract and nothing else. Dactylysis is fluid collection within the lacrimal gland. As you can see, it lies along the medial campus. This has an excellent prognosis. 80% of them spontaneously regresses, either with advancing gestation or in the first year of life. 20% of them might need some sort of intervention. Literally, what is important is that you exclude. So usually frontal encephalocele are associated with hypertelorism. That you need to seek and rule out. And if you think the orbits are normal and the central space appears normal, especially if it's at towards the medial campus, it is dactylysis, and as an extreme prognosis, 20% of them can be bilateral. Of course, it can be seen even on the 3D images. Calvarium, frontal bossing. This picture is typical of achondroplasia. Frontal bossing, flattened nasal bridge, slightly upturned nose. This pattern can also occur in thanatophoric dysplasia, but thanatophoric dysplasia will have severe limb abnormalities as compared to achondroplasia. One point to note in achondroplasia is that most often it will have a near normal 20-week scan. Near normal 20-week scan. There will be marginal increase in size of the head or the cranial parameters, borderline normal femur length. For example, if it's a 20-week scan, it will be 18.4, 18.3, but it will not be really short because achondroplasia presents itself between 21 to 27 weeks dominantly, and you can easily pick it up only after 24 weeks. Before 24 weeks, it is not easily, it cannot be easily picked up, and this needs to be, we need to be aware of this. So because it's a non-lethal skeletal dysplasia. Only lethal skeletal dysplasias can be confirmedly picked up between the first trimester and the second trimester. If you have sloping forehead, as you can see over here, it indicates most likely microcephaly. Previous one is macrocephaly, frontal bossing. This is microcephaly, sloping forehead. This forehead slopes mainly because the brain growth is the impetus or is the stimulus for calvarial growth. If there is a small brain, there is microcephaly, then the need or the pressure on the bone to grow is less, so you have this type of a sloping forehead. And also you can note the relative prominence of the eyeballs in comparison to the calvarial. The calvarial's eyeballs appear prominent. That's because the growth of the eyeballs is normal, and it's issues with the brain. So again, there is a DD right from infections to syndromes. You need to run your syndrome study. But when you have a defect in the calvarium, it can be small, as you can see over here, a small portion of the A small portion of the brain, as that of meninges and the fluid, seeps out and forming external bulge. You can see it. You can see it. So usually when there is a defect, the same principle of spina bifida comes in. We will have reduced fluid. The subarachnoid spaces will be usually flattened out, and there will be less fluid in subarachnoid space because lots of fluid comes out, and also a bit of the brain. So if you see a little bit of reduced fluid outside a subarachnoid, the subarachnoid spaces, we need to seek for, just as we look in terms of the spina bifida, you need to seek for other defects. Now, if the calvarium is completely absent, it's called acrania. And this picture of acrania with some portion of the brain you see in the first trimester, because the amniotic fluid lyses off this brain tissue by the time it reaches 20 weeks. So it follows an acrania exencephaly sequence before it becomes anencephaly. In anencephaly, there is no brain. The brain appears bald. You have the frog face-type brains. You can see over here. Orbit slips, and there is absolutely no brain that slips bald. It has been ignored. Now, the calvarium can appear lemon-shaped. A small portion of them can be normal variants, but when you have a lemon, you need to go and check at the posterior face. You can see slightly parallel shaped cerebral peduncles. As you can see, little bit banana shape. Of the cerebral. So this is typical of GRE2 malformation with the spinal lemon shape. This slightly lemon-shaped thing can also appear when there is a premature suture closure of the metopic suture. It's a 20-week, slightly closed. Usually we see this size of 20 weeks, thus causing an increased biconcavity of the frontal lobes. Now, this is brachycephaly, coronal feature. Coronal suture in stenosis, sclerocephaly, sagittal suture. This is the typical flower leaf skull. Both coronal and sagittal sutures. This is typical in the fluid too, and also few other symptoms like Carpenter's and fibers. So these are the diagnoses. And of course, brachycephaly can also be seen downstream. Once you are through with the shape of the skull and the scalarium, you need to look at it. Now, if you are seeing too much of the brain in the near field, that is not a good sign. You see too much of the brain in the near field, repeat, is not a good sign. This is how normal 36-week skull looks. You see too much brain at 36 weeks, is not a good sign. You need to look for brain or calvarial mineralization abnormalities. You need to do the ping pong test. You just see the mild pressure on the probe and see the flattening of the skull bones at 36 weeks. This is a case of brain calvarial or bone demineralization, case of osteogenesis imperfecta. You can see the fractures over here. So we need to, as you can see the fractures. And so we need to look for echogenicity of the calvarium as an indicator of brain mineralization too, as part of our brain scan. Coming to the extremities, clubfoot is one of the commonest extremity of foot problems that we encounter. We call it clubfoot when the long axis, the coronal long axis of the foot can be seen along with the coronal long axis of the long bones, the lower leg long bones. Foot long axis, coronal axis can be seen along with the long axis of the long bones. Then we call it clubfoot. As you can see over here, most often, the first thing we need to do is what else? The question you ask is what else? nothing else. So it has an excellent prognosis. Of course, it will need some sort of conservative management or maybe a surgical treatment too, but it has an excellent prognosis. 1 to 2% of clubfoot. If it is isolated, association with chromosomal abnormalities or aneuploid is 1 to 2%. But if there is any other association, the association with aneuploid jumps up to 10 to 30%. When it's isolated, it's within 1 to 2%. When it is associated with other abnormalities, depending upon the nature of abnormalities, the aneuploid risk jumps up to 10 to 30%. So the first question we see at clubfoot is what else is there? So you need to do a thorough anatomy screen and confirm it's just isolated. If it is isolated, it has an excellent prognosis. Now this is rocker bottom foot, the convexity of the sole. Convex soles. Here again is bilateral. So these are slightly more complex or more associated with aneuploid, especially trisomy 18. Rocker bottom foot is associated with trisomy 18. So when you see a rocker bottom foot, before you call it isolated, you need to really run a thorough screen, especially for things associated with trisomy 18, choroid plexus cyst, interdigitating fingers, clenched fists, single umbilical artery, and other markers of trisomy 18. It has no association with trisomy 21. It is associated only with trisomy 18 and few other symptoms. And it is not associated with trisomy 21, same as clubfoot. Clubfoot also is not associated with trisomy 21. There is a slightly increased risk of trisomy 18, and trisomy 18 invariably presents with growth restriction. Polydactyly, as I mentioned, can be preaxial or postaxial. But the first and most important thing that you need to do in an approach to polydactyly is count, and recount. You need to count it so many times till you are absolutely sure, because overdiagnosis and underdiagnosis is quite common with polydactyly. And first thing, you need to classify them as syndromic and non-syndromic. And non-syndromic, most commonly, it is familial. So you need to seek for history from the parents and the relatives, whether there is family history of polydactyly, and if there is no family history, then you need to again run a search for syndromic causes, other any associated anomalies. Syndactyly, again, as you can see over here, fusion of the fingers, it can, this one. Again, same as polydactyly, familial, most common, syndromic association, much less common, but we need to be aware. There is a syndromic association with syndactyly too, but usually if rest of the fingers are normal and rest of the fetal anatomy is normal, it's likely to be a sporadic occurrence or familial. Clinodactyly, radial deviation of the distal portion of the fifth digit. Clinodactyly. 2 to 4% of normal individuals can have it. 60% of Down syndrome babies have it. 2 to 4% of euploid fetuses and 60% of Down fetuses are clinodactyly. This is of course, again, as usual, ask for family history. If there is a family history of people having a curved, radially deviated little finger, then it's likely to be familial. And of course, we need to do a thorough screen. This is associated only with the Downs. The increased risk is predominantly with the Downs, and that is what you need to check for. Retrodactyly, cleft, leg or cleft, and lobster claws. It's also called lobster claw malformation. So, again, look for family history, look if it is isolated, look for facial clefts. Facial clefts, when associated, cleft lip, cleft palate, when associated with ectrodactyly, have an association with ectodermal ectrodactyly syndrome. So one thing you need to really seek when you see a case of ectrodactyly like this is facial clefting and of course family history. Otherwise, they have excellent prognosis and they are isolated. They just need some little corrective surgeries if at all. Interdigitating fingers, overlapping fingers, interdigitating fingers, or clenched fist. Diagnostic for trisomy 18. It is literally diagnostic. trisomy clenched fist, and also for other muscular and neurological malformations like after diagnosis, but very typically seen with trisomy. Trident hand. 3 clusters of fingers. 1, 2, 3. 8 counters. 5 fingers are spaced out and have a typical trident type appearance. Limb reduction defects. These are absolutely crucial from a radiology. You can see that there's a sudden stop reduction of the limb over here just below the knee. Other lower limb appears okay. There's only one side. If this limb lies posterior, or if this limb lies in a set of slightly oligoheteronomous setting or reduced like a setting, you can easily miss it. You can see it up to the knee and you can just pursue it. One big jump in scan is never pursue. Always see, document only what you see. If you are not seeing it, document that you are not seeing it. Limb reduction defects, increased associations. This is very, very clear. And as I mentioned earlier, always check for 3 segments. 3 segments in this. Median is when one segment of the limb is absent. Usually the hand or foot is present, as you can see over here. Here you can see the hand attaching directly to the index. With the level of the area. The mid segment of the upper limb is missing. Neuromelia is absence of one segment. 3 segments are there. 3 segments in the limbs you need to look for, and here the middle segment is absent. This is the fibula. Here, this like the other one there is only single line. Here, 2 blocks. See the right place here. You need to see for these things. Radial ray malformation. This is strongly associated with symptoms. So once you see a radial ray malformation, usually the radial bone is absent, plastic, thumb is usually abnormal, and there is a radial absence or deviation of the carpal bones too. So this has a strong association. 1, first of course it can be familiar. 2, all these hand part syndromes, Ultrasound, Fanconi's anemia. A list of symptoms are available. Again, seek where it's facilitated, and the post-natal impact will be based on whether it's isolated or whether other associations are seen. And it is a very strong association with syndrome. There's a big list of symptoms, I wouldn't go to it, but it is a strong indicator or a sentinel sign or a lead sign that you need to thoroughly evaluate the other structures in the fetus. Bowed long bones, as you can see over here. The first thing that you need to go and see is whether it is isolated. Now this is a femur. It's an 18-week femur, grown up to 15 to 16 week size. 18-week femur. There is a bone, there's a mild angulation over here. If this femur is isolated, then the other femur is normal. Most likely this bone is local familial deficiency. Approximately local familial deficiency presents this isolated bowing with mild reduction, 8 to 2 weeks reduction. This is focal familial deficiency. But if the presentation is generalized, multiple other bones are also shown, then you need to look for other abnormalities, including skeletal. Now, this is 21-week fetus with a 15-week femur, typical telephone appearance. One thing that we need to observe to call dysplasia lethal, what is most striking about this fetus? It has more soft tissue for its bones. In lethal skeletal dysplasias, in fact, any skeletal dysplasias, especially in lethal, it is the receptor or the genetic material for the bones that is abnormal, but the soft tissues is normal. So there is more soft tissue for the smaller amount of bone. The soft tissue is for a 21 week size fetus, while the bones are grown only for 15 weeks. That is why, as you can see over here, the soft tissues will be prominent. If soft tissues are prominent, you can directly think it's likely to be a skeletal dysplasia, predominantly a baby. It is, if you see prominent soft tissues, that is the first strong clue. Second is a small thorax. You can see the typical bell shape there. Ribs and long bones have the same growth gene, FGF receptor gene, fibroblast growth factor receptor gene. Both of them have the same receptor gene. So whenever long bones are small, you will have the ribs small. When you have the ribs small, there will be pulmonary hyperplasia, and these babies die not because, these are lethal, not because of limb shortening, but because of small thorax. But because of pulmonary hyperplasia, these babies die in the first few days. Again, the heart appears large because the thorax is small. You can see the abnormal contour shape of the rib bones. Cardia occupies a large portion of the thorax. That's because of the small ribs causing pulmonary hyperplasia. So these are indicators for a lethal skeletal malformation, skeletal dysplasia. So one rule is comparing the femur with the foot. Foot grows irrespective of any skeletal dysplasia. But in normal fetuses, foot and femur are roughly the same size. So if the femur is shorter than the foot, you suspect that something is abnormal. You do not call them skeletal dysplasia yet, though it's mentioned in text as less than 1 is suspicious. Less than 1 is definitely suspicious for a dysplasia, skeletal dysplasia, but if it is less than 85%, less than 0.85, then you are seriously thinking of something seriously abnormal, because some Indians or some people generally have a relatively short femur. But what is more important is the lethality. As you can see over here, femur and thoracic circumference, the rib, measure the ribs. When compared to AC, they tell us about the lethality of the dysplasia. And all lethal dysplasias, all ALL, all skeletal lethal dysplasia can be diagnosed in first trimester. Just showing the points that I told, more soft tissue for the bones, and if you can, if there is any suspicion, even a 12-week scan, we measure the femur length and the AC. You can measure the rest too, but if there is an abnormality, if it's less than 0.16, it is suggestive, less than 0.160% of the AC. Often is less than 60% of the AC, as you can see over here. Previous video. Here it's 12%. FLAC is 12%. 0.12. So this indicates it's a lethal skeletal dysplasia. So if you have an isolated mildly soft femur, it is most likely it can be familiar or idiopathic. It can be a marker for early FGR. HC, head circumference and AC can still be normal. If it can be a marker for early FGR, of course, Down syndrome has an increased association with short femur and humerus, and of course, Turner's too. Less common causes in the 20-week scan. In the 20-week scan, achondroplasia will be really mildly short. Osteogenesis imperfecta, as I mentioned. Now, this is a body stop anomaly. Severe disruption of the ventral wall, thoracoabdominal defect, cardia is seen bulging out. There is severe kyphoscoliosis. The spine, you cannot see the entire extent of the spine. You can see the amount of scoliosis that's happening there. Kyphoscoliosis. Umbilical cord is short. The fetus is attached to the placenta. And these are lethal abnormalities, but it's important. I think I will start here a little late. And so to summarize, the topics that we discussed today: skeletal and facial abnormalities, craniofacial abnormalities, they have a manifold impact on the fetus, the families, and the care providers. On the fetus, yes, there is obvious aesthetic abnormality, aesthetic difficulty. In addition to that, there is an emotional, psychosocial, even if it is a normal variant, psychosocial abnormality the baby has to do. And this external aesthetic and the cosmetic abnormality puts added pressure on the radiologist in terms of a medico-legal litigation and puts us more at risk and gives us a warning. So it is important that we use a systematic checklist. Always document what you are seeing. Always write what you are seeing. You see the face I have seen, the orbits, nose, lips, and that's it, nothing else. If you're seeing the uvula, document you're seeing the uvula. You're not seeing, just write what you see and what is the extent of long bones that you have seen. Only the long bones, the hands, feet, and finger counting is not part of any protocol, and so finger counting is not part of it. But of course, if you see any of those, polydactyly, syndactyly, yes, they are a clue for aneuploidies, clue for syndromes. So you can use them as a clue or a sentinel sign or a lead point. From there, you can build on your assessment. But fetal counting, fetal finger counting or digit counting is not part of protocol. Similarly, the ears. That's why I didn't touch the ears. Ears are also not part of any standard international guidelines. That's why I have omitted it. So once an anomaly is found, it is important that we confirm it's only isolated or it occurs as a cluster. And if it occurs as a cluster, it is important that we throw more light into that anomaly, whether it is likely to be a correctable abnormality, likely to be a syndromic abnormality, and if it is a syndromic abnormality, what type of further testing needs to be done, whether invasive test will help, and also the recurrence risk, if it can be predicted, is an important part of assessment of the fetal cranioskeletal system by radiologist. We will stop here. Thank you. Any questions? If you want, you can put in our DCT chapter WhatsApp group and I will